Hi, and thank you so much for the invitation to present today on a topic I am so excited about. So, chronic pain is a growing epidemic, and currently severe pediatric chronic pain affects between 100 to 160,000 youth. And due to healthcare utilization and lost productivity, it costs society upwards of 7.2 billion Canadian dollars per year. If pediatric chronic pain is left unmanaged, 2 out of 3 youth with chronic pain will become adults with chronic pain. In looking at the mechanisms underlying the development of chronic pain, functional neuroimaging studies have found that as pain transitions from an acute to a chronic state, there is less engagement of the sensory motor regions of the brain and greater engagement of the limbic regions of the brain, which suggests a transition from more sensory motor processing to greater memory and emotional processing as pain becomes chronic. Not surprising then, given the the brain and the brain emotional areas being engaged, chronic pain has many comorbidities such as anxiety and depression and post-traumatic stress disorder. And longitudinal studies in youth have found that even if their pain symptoms resolve, they may develop comorbid and internalizing mental health conditions as they become adults. So in 2014, the Alberta Children's Hospital created the first Canadian Intensive Pain Rehabilitation Program, or IPRP, which they based on previous programs largely in the States. And this program was developed for low-functioning youth between the ages of 10 and 18 years with severe chronic pain who do not have access to or who do not respond to typical outpatient therapies. The goal of this program was to help youth return to their normal daily functioning. So not necessarily to resolve their pain altogether, but to have them resume activities that they used to participate in prior to becoming extremely debilitated by their chronic pain. And this program was developed so that it's offered for 3 weeks, 8 hours a day by an interdisciplinary team. So shown here is what a 1-week schedule would look like for 2 youth going through the program. And as you can see, every minute of their 8-hour day is accounted for. And there's a variety of therapies that are introduced, such as family therapy, art and music therapy, psychology, occupational, physiotherapy, anesthesiology. It's about 13, I think, different therapies altogether that they go through over the course of their 3 weeks. A bit unique to our program is that it's the only intensive pain rehabilitation program in Canada that's offered nationally to youth. There's another program, I believe, in Toronto, but it only services youth in Toronto and the surrounding area. Another unique aspect to this program is that these programs have typically been designed to specifically target youth with neuropathic pain or specifically CRPS, whereas we open our program up to youth with all types of chronic pains. And although neuropathic is still the primary condition that we see, we've also had a number of youth come in with chronic headache, musculoskeletal pain, and as well as abdominal pain. So in order to assess improvements over time in our youth and also evaluate our program, we began to introduce self-report questionnaires, and we provide these questionnaires at baseline, so prior to youth starting the program, at discharge, so when they finish the program 3 weeks later, and then we have them fill out these questionnaires, the same questionnaires, again at 3, 6, 12 months, 24 months, and 36 months post IPRP, and both the patients and their parents fill out these questionnaires. The questionnaires assess pain, functional disability, anxiety, depression, and PTSD symptoms, as well as other questions as well, but these are the things I'll focus on for this talk. So shown here are the results from 36 youth that went through the program between August 2016 and March 2020. And it's showing the results from their baseline and discharge assessments. And so you can see that their pain interference, functional disability, anxiety, depression, PTSD were all significantly improved at the end of the program. And the only value we didn't see change was their pain intensity. And again, the focus of the program is really to improve their functioning. And so having them resume normal daily activities, it's not meant to focus on reducing their pain. The thought is that as they resume their normal daily activities, their pain will dissipate over time. However, Dr. Karen Hurtubise did look at our data longitudinally and compared our IPRP data over 1 year to the data collected from our outpatient programs on a few of these parameters. And she found that pain interference remains significantly improved at 12 months post-IPRP. So the program is doing what it was meant to do, and that's to reduce the amount that pain is interfering with the daily lives in these youth. However, quality of life and their depression scores remained unchanged in the IPRP group. In the outpatient group, they saw significant improvements in quality of life, but no improvements in depression scores either. So what this data really told me is that we are achieving our goal with this program in having youth have pain be less interfering with their daily lives. However, there's still room to improve upon this program so that even though they're resuming activities, we can also improve their quality of life and their mental health conditions as well. Another way that we are assessing these youth's outcomes are using neuroimaging. And in 2016, we added a neuroimaging component to IPRP, where we scan all eligible youth at baseline and discharge from the program. And we acquire both structural and functional MRI data from the youth. For the fMRI data, we specifically use blood oxygenated level dependent signal changes during the presentation of validated pictures of facial affect. So looking at happy, fearful, neutral images in relation to a scrambled image in the scanner. And the reason why we show a scrambled image in addition to the neutral face is because some people actually do find that neutral face a bit threatening. And so we use the scrambled image as a true neutral. And we randomize these photos into 4 blocks and present them 4 times. So the photo presents for 200 milliseconds, and then there's a 300 millisecond crosshair that appears. And this happens over the course of 10 minutes. And so these faces flash very, very fast at the youth in the scanner. When we looked at their changes in brain activity over time, we found that at baseline, regardless of the facial expression, youth were very hyper responsive to both in their brain to the happy, fearful, and neutral faces relative to the scrambled image. And by discharge from the program, we saw a decrease in that hyperactivity, specifically within the dorsolateral prefrontal cortex area of the brain, which is really involved with cognitive processing and is very interconnected with those emotional areas of the brain that I had talked about earlier. When we compared this decrease in dorsolateral prefrontal cortical activity over time and to their outcomes, we found that this decrease was correlated with a decrease in their PTSD symptoms over time as well. And this is after accounting for the time between scans, their age at scan, the type of pain condition they had, and their functional disability. So we're seeing more an observational improvement in their brain that is associated with their self-improvement throughout the program as well, which is really exciting. Now, shortly after I had done this preliminary data on the preliminary assessment of our functional MRI data, I had attended a talk at the Alberta Children's Hospital by Dr. Adam Curtin, who's an expert in brain stimulation. And he was presenting on his project looking at repetitive transcranial magnetic stimulation in youth with treatment-resistant depression. And he found significant, by stimulating the dorsolateral prefrontal cortex, he was able to significantly decrease depression in youth that had treatment-resistant major depression. So they weren't responding to medications to treat depression. So this was really exciting because depression is one of the areas that we aren't necessarily seeing improvement over time in youth that have attended IPRP. And they were specifically targeting an area of the brain that we are seeing changes over time with our program. So this got me wondering whether or not we could use repetitive transcranial magnetic stimulation, or RTMS, to really target this area of the brain to improve chronic pain and associated outcomes in our youth going through the IPRP program. And so the first thing I did was went to the literature to see whether or not RTMS had been applied for chronic pain populations. And I found that there was really two areas of the brain that people were targeting. The M1 is really where the literature started, so the primary motor area. And then more recently, people started looking at the dorsolateral prefrontal cortex as well as a treatment for chronic pain in adults. And importantly, both of these regions do have connections with more of these subcortical gray matter areas that we know to be involved in the chronification of pain. So theoretically, both should be capable of improving both chronic pain and associated symptomology over time. And looking at the mostly pilot RCTs stimulating these two areas, largely there are improvements in chronic pain and associated symptomology. However, there is variability across studies, and I think that's because we don't really know the optimal protocols at this point in time for treating chronic pain with RTMS. So we don't know what the optimal strength of stimulation should be, or what the optimal location in the brain should be, or the length of time that they need to be stimulated. At what point do they need top up to their stimulation? Can it be an add-on to other therapies, or some studies have had them stop therapies and use this as their sole treatment. So I think this really contributes to why there is variability in the outcomes, but generally speaking, as I said, most of the RCTs do show successful improvement in the reduction of chronic pain over time, and particularly in my area of interest for stimulating the dorsolateral prefrontal cortex. Interestingly though, all of the studies have been done in adults, and to the best of my knowledge, I haven't seen anyone use RTMS to treat chronic pain in youth, which is interesting given that treating youth might be the most optimal time given the ongoing development of the brain. So seen here is, on these brain images, is the dorsolateral prefrontal cortex area highlighted. And you can see that this is one of the last areas of the cortex to develop in youth. And so it's the most plastic and susceptible to input. And so if by targeting this area of the brain during adolescence, we might be able to make real changes in terms of interrupting this persistence of pain. Importantly, even though RTMS had not been applied in youth for the treatment of chronic pain, it has been used for several other disorders in youth, including concussion and epilepsy and depression, and it's being used for tics as well. So over almost 4 million stimulations now at the Alberta Children's Hospital, we see that this is very safe technology, and that generally it's only associated with headaches, mild neck pain, nausea, lightheadedness, usually when they first start these stimulations, and then these tend to go away with multiple sessions. And then emerging in the literature now, we also see that people are encouraging RTMS and combining it with other therapies as really a way to enhance the benefits of the therapy that they're going through. So this really would make it a perfect addition to our IPRP program. And so you might be wondering at this point, what is RTMS? And it is a magnetic coil similar to an MRI, but less powerful. And it produces small electric currents in the region of the brain just under the coil via electromagnetic induction. And using their MRI images, we can really hone in on the specific area of the individual that we want to target. Specifically in my case, it would be the dorsolateral prefrontal cortex. And at the Alberta Children's Hospital, we have state-of-the-art neuronavigation system and the world's first pediatric RTMS robot for precision. So really advanced novel equipment that we can apply to these youth. And so we had decided to use an open label clinical trial to examine whether adding RTMS to the IPRP program can enhance the brain changes and outcomes associated with the standard care, IPRP care. And so what we're doing is we're applying RTMS every weekday for three weeks. So every day that they have IPRP, they would also now have RTMS. And we're stimulating their left dorsolateral prefrontal cortex at 10 hertz. And each train delivers 40 pulses, which last 4 seconds long, and then they have a 26-second break. So the whole treatment lasts 37.5 minutes. They have 75 trains, and they have 3,000 pulses delivered to the dorsolateral prefrontal cortex. And this is what a 4-second train sounds like. So you can hear those electric pulses being delivered to the dorsolateral prefrontal cortex, and then they would have a 26-second break in between. So shown here are the left two columns are the data, the historical data from our IPRP program prior to adding on the RTMS intervention. And the right two columns are of the first 6 youth to go through IPRP with the additional RTMS. And now 6 youth doesn't really give us enough power to say anything definitively statistically at this point, but we are seeing a less than 0.05 value on pain interference. So this is consistent with what we found before, that pain interference is significantly reduced in youth that go through the IPRP program. So this is really positive. It says that, you know, by adding IPRP, we're not having worse outcomes for these youth. It's consistent with what we found before. And then when we look generally at the data, we are seeing large reductions in functional disability. And interestingly, we're seeing a pretty big decrease in PTSD symptoms, which was what we found the original correlation with the dorsolateral prefrontal cortex in our preliminary data. So a lot more work to do. Our goal is to recruit 25 youth, and typically we only bring in 2 to 4 youth per quarter. So this will take some time to collect all of the data, but hopefully I can come back and share more of our outcome data, not only between baseline and discharge, but also longitudinally to see whether or not the addition of RTMS is improving our outcomes in IPRP youth over time. The other thing that we're doing is asking both parents and youth to rate of the 13 interventions they're receiving, what are the most helpful, 3 most helpful, and 3 least helpful. So we asked both the parents and the youth. And these tables are a bit much to go through, so I've summarized it more simply for you here. But basically at baseline, prior to doing anything with the program, the parents thought that physiotherapy, psychology education, and group physiotherapy would be the most helpful for their youth for going through IPRP. And youth thought brain stimulation, also thought individual physiotherapy and occupational therapy would be the most helpful to them. Parents thought the least helpful would be the academic support, art therapy, and family therapy. And youth thought the least helpful would be art therapy, academic support, and group physiotherapy, and nursing medical assessment also ranked under the same least helpful for youth. And so parents and youth agreed that art therapy and academic support would be the least helpful prior to starting the program. At discharge and 3-month follow-up, and I combined these 2 time points just because there was too much variability to look them at them individually at this point, with only 6 youth having gone through the program. But importantly, parents thought that individual physiotherapy, individual psychology, and brain stimulation was the most important or most helpful for their youth. Youth agreed that individual physiotherapy, individual psychology were the most important, and then also said family therapy. And they ranked brain stimulation as the 4th most helpful. Again, parents and youth both thought the art therapy and academic support were the least helpful. Parents thought group physiotherapy was also the least helpful, which was funny because that was something they thought would be the most helpful prior to starting the IPRP. And also funny is that youth not only thought that family therapy was most helpful, we also had youth thought was the least helpful. So for some it was very helpful, and for some it was not so helpful. So what this tells us is that with these rankings, we may be able to pare down our program in the future to the interventions that are the most helpful for youth, but it might not be able to leave it up to choice to the families, just because we can see that sometimes what they think will be most helpful to them in the beginning is in reality not necessarily what is the most helpful for them. But we potentially tailor our program to individual needs as well. So for some youth that really need the family therapy, that might be really beneficial to them, whereas for the other ones where they don't need that, maybe it's just really not so beneficial for them. And important for my study, brain stimulation appears to rank very highly among the families, and that'll be important for us going forward to see if that continues and how that psychological influence of viewing brain stimulation positively helps us. So overall, chronic pain is a growing epidemic, and if left unmanaged, it can lead to persistent pain problems and comorbid mental health conditions. As it transitions from an acute to chronic state, there's greater engagement of brain regions involved in emotional processing, and these emotional brain areas can be targeted via directed brain therapies, such as brain stimulation. And it'll be yet to be determined whether or not the addition of brain stimulation can add further benefit to our IPRP outcomes. And I just want to say thanks to all the patients and families and our teams that have really helped drive this research forward. And thank you for your attention.
Thank you so much, Dr. Miller. And again, we have a ton of questions, and I was just going to ask a couple of quick ones before we move on. One of them is, in terms of the expectation and the introduction of this, with a pediatric population, is it easy to get them on board with it? Is it easy to introduce it to them?
Yeah, I mean, I think you could see with, we asked them at the beginning what they thought would be the most helpful, and youth right away ranked brain stimulation as what they thought would be the most helpful therapy for them. So I think a lot of them are very excited about the idea of partaking in a new intervention that maybe they hadn't heard about before. And we really tried to answer any questions or dispel any fears at the beginning. We even send like an example video of like what the machine looks like and what the stimulation sounds like, to really help quell any fear. But it seems, because it's a more medical type intervention, I feel like it's a lot easier for the youth to get on board and grasp than necessarily the idea of doing more physio or psychology. But that said, at the end of the day, they rank physio and psychology very highly once they realize the benefits from it. So that's not to say anything less about those therapies, are obviously very important to the program.
Well, and I think it's really interesting that even when it came to adding RTMS, it really is in the same way. It's about adding to increase effectiveness. And I really like that you also referenced the ability to pare down by asking people what is most effective. For you, were there any surprises in terms of where the shifts were from pre to post in terms of perceived effectiveness?
I think it's really too early to say at this point whether or not there is a true effectiveness of adding on the brain stimulation. Like, I think a lot of our numbers are looking very similar at this point, and we just need more data. I'm not sure if I'm answering your question or not, though. But yeah, I think it still has yet to be ruled whether or not this is a good and helpful addition. It seems that the parents and youth think that it's a useful addition, at least from their perspective. But in terms of their outcomes, we still have to assess that. And what I'm really interested to see is over time, whether or not the addition of RTMS can really help to improve those longitudinal outcomes where we're seeing some fallout after they're discharged away from the program.